Thank you, everyone, and thank you, Antonia, for inviting me here today. I'm going to talk about my PhD. So I'm a PhD candidate at the University of Bristol. And I want you to reflect a little bit on this picture. So you can see the robotic hand is fully extended, but you can see on the other side there's a black woman's hand, and it's just one finger, okay? So this is just about reflecting a little bit what's happening for women who are not white, who have different backgrounds, and who experience health inequalities in the health system. So I just wanted to say that I'm a midwife, so I'm just going to walk you through this path, and this is with the eyes that I'm seeing it. So I'm a midwife. I've been practicing in hospitals for 10 years, and now I'm a researcher. So I'm a full-time researcher at the University of Bristol, undertaking that full-time PhD. So the way I see the future, so I met by chance Antonia online. I saw her presentations about the project that she was doing, and I was very interested about health inequalities and how some women, they have different experiences of care during childbirth, so pregnancy, labor, and afterbirth. So I was very interested to see whether we should be including ethnicity, for example, social determinants of health, social demographics in algorithms to help to predict and personalize care for women. So this is the starting point. So I'm not going to bore you with all the limitations and all the controversies that exist around CTGs, which I probably know you all know about. But I just wanted to point out about the importance of social determinants of health. So there's strong links between women's health, and not just related to clinical factors, so whether they have diabetes, whether they have hypertension, is beyond that. So it's whether about they have access to health, do they live in a polluted area, do they live in an area where it's easily accessible to transport, for example? I know some of the speakers before, they have mentioned on a few of these issues as well. So it's about how all these factors, non-clinical factors, social determinants of health, influence the health, maternal health, and as well the fetal health in utero and afterwards. So in the UK, but it's not just purely in the UK, US, Netherlands, any country around the world where women are the minority in that country, they do experience adverse events. And when we compare them to white women, for example, in the UK, black women have 5 times more likely to die than white women, and Asian women are 4 times more likely to die than white women. They also have poorer experiences of care, and also their babies. So those things are just some points to reflect when we are trying to come up with some algorithms, and we consider that everybody is the same, and we're not. We have different outcomes, we have different backgrounds, and that is all interconnected somehow. We don't know exactly what is the link and how should we be treating perhaps some women differently, but it's something that we really need to start thinking about, creating more evidence and thinking around these issues. So that's why I come up with this question for my PhD. Should we be using ethnicity or any other social determinants of health in those algorithms that they are going to support clinicians in the decision making during labor? And by social determinants of health, for those who are not aware of them, they are the conditions that you are born with, you live with, and then you grow, age, and die with. Some of them, they might be changeable. Some of them, they're just static throughout your life. So I know this is a very controversial question, and I started with, can we use it? Now it's, should we use it? Because it touches lots of ethical concerns. I had lots of discussions with very interesting people, and yes, there are controversies around it. There are some ethical issues as well, but nonetheless, we need to still consider all this and how interplay when we are building this and developing these algorithms. So in my project, I'm supervised by Professor Kenton O'Hara. So he's a professor in human-computer interaction at the University of Bristol. Antonia and Luba, they're also supporting me with the data side of things. I'm also, just to remind you, I'm a midwife, so I'm learning how to do some stats, also how to program and how to understand all the side of things. And I'm also supported by Associate Professor Natalie Darko. She's an expert in sociology, and she's also an expert in health inequalities as well in the UK. So I want to take a different angle as well, and I want to call it like a mixed methods research, because I wanted to, it's a very complex issue, as all you can see, and I want to touch on very different things. So to me, I'm very passionate about women, and because of my nature as being a clinician, I'm really interested in, what do they think as well? How can we bring them in the conversation if we are going to do something about them? I think it's fair if they are also joining in all these processes of creating and developing the algorithms. Also the clinicians, I'm a clinician, so I can see now both sides of the situation, and yeah, it's very interesting, and also learning what are the socio-technical contexts of labour care, for example, and the labour room, which I'll be touching in a minute. Also the data. I will have the opportunity to look at data sets from Oxford, Cambridge, and other areas in the UK, hopefully. And it's just trying to see how can we identify this, the link between social determinants of health and the health outcomes. Because there's more and more evidence. For example, there's a paper that recently came out in December 2023. There was a consortium of clinicians, and they're calling for more evidence on the link between social determinants of health and birth outcomes, because we know very little about it, yet we know that social determinants of health play a very important role in women's health and fetal health. So recently, sorry about that, I've undertaken a qualitative research with 18 clinicians. So I had 3 student midwives, I had 13 midwives, and 2 consultant obstetricians from the UK, and that was a fair representation of Scotland, Wales, and England. And I was talking, so the main driven for this qualitative research was trying to identify biases that exist in the current use of CTGs, how clinicians interact with the current technology, which is, CTGs, telemetries, centralized fetal monitoring, where you have a monitor outside the room, and you can see all the CTGs that are happening in real life in the other rooms. So it's just trying to understand, taking a step back and thinking, okay, if we're going to introduce an algorithm in clinical practice, what are the things that we need to think about in terms of biases? What biases are clinicians consciously or unconsciously introducing? And, when they are going to have these tools to support them in their decision making. So it's been quite interesting and, unsurprising. We are all humans, we're not robots, so we all bring biases. However, some biases are more evident than others. For example, things like accent, things like something visible in your appearance, wearing a headscarf, for example, the color of your skin, the clothes that you're wearing. For example, I don't think it will be any surprise for anybody, any clinician in this room, in the UK, and we've all done this. If you're looking after a doctor, or the wife of the doctor, or you are looking after a lawyer, your behavior will change. You are going to make sure that your care is top, okay? These women probably are the ones that precisely need less of this extra care. Are the women who are not speaking English, who have barriers to accessing care. Those are the women who really need you to be and run the extra mile. However, are the other way around, because we have that fear of litigation. They are more likely to know and identify whether you have done something wrong, and they have the power to say, hang on a minute, I'm going to complain because you haven't done your work properly. However, all the other women who suffer racism, health inequalities, are less likely to raise these questions and being able to identify, oh, something is wrong here, because I'm very grateful for the care that I've received. So it's just trying to understand all the socio-technical systems around the labor world. it's also very interesting, although it wasn't the main objective of my research. They were very happy to talk about, and very loud as well, how they interact with the current technology. So with the CTGs, as I was saying, in the UK sometimes there's a bit of a postcode lottery, so not every hospital now have centralized monitoring, so only a few units. So it was interesting to observe that the behavior of the clinicians have changed as a result of this introduction of the centralized monitoring. So again, it's just a big screen outside in the main staff room where every clinician can see all the CTGs. So what I've been observing throughout these whole interviews and what clinicians have been saying is that it gives clinicians outside the room an unsolicited permission to go inside the room, because all they see, there's some loss of contact, or there's what is meant to be an acceleration, but then they go into the room without even knocking, and the midwife is like, what are you doing here? I haven't called you. And the baby is the head is just in the perineum, just being born, for example, or if they just gone to the toilet. So it's just trying to understand how the technology has affected and impacted the way we behave, the way we, act around monitors and CTGs, and the other way around. So midwives, especially if they're a bit younger and being less senior, they might rely that somebody's watching the CTG, which probably is not, because it's a very busy unit. We have less and less midwives and obstetricians. But yes, some midwives might rely on, well, somebody's watching it from the outside, so if there's an issue, they will come in. So it's just, again, trying to understand what's happening with the current technology before we introduce something new. And I proposed clinicians, we were just discussing how would they feel about introducing within that tool certain variables that, again, they're not clinical variables based on socio-demographics, ethnicity, just trying to see whether they looked at CTGs differently, whether the woman was from a certain background or had certain characteristics. And some of them thought it was about profiling. So what I'm finding, I think, is just nowadays, in 2024, the concept of racism has evolved in a way where if you don't, it's just trying not to focus too much on ethnicity, because otherwise you might feel like you are being racist. So it's kind of trying not to talk about it and saying, oh, I don't see color, I treat everybody the same. But that is not the way we should be going. And some clinicians thought that having access to all this information for that CTG, given that CTG context, will make them increase their biases. However, there were other clinicians that they saw the value of having access to all these other variables that they are not clinically directly related. And it's about, again, that provision of holistic care, provision of more personalized care, because you know more about the circumstances behind that woman and putting more context on that CTG. I also wanted to ask women what they thought about their experiences of CTG. So I've run a couple of projects. So one of them was a coffee morning, and I had 12 women. They were mainly from Somalia and the Caribbean. And I also ran a public engagement project with 7 women as well, from different ethnic backgrounds and mixed ethnicities. And again, they know about health inequalities. They know they have worse outcomes. They know they're a statistic, but then they feel like nothing has been done about it. So they do feel like we, as in the research arena, we should be doing more for that, because this is not enough by saying to everybody, you're more likely to die. Okay, what are you going to do about it? So they feel like there should be more done around these topics. And this is what they were saying, no decision about me without me. They really want to be involved in these things, because recently in the UK, there's a tool about, I know it's not related to CTG, it's about miscarriage risk. And we know as well that black women and with other intersections are more likely to have a miscarriage, yet that ethnicity component and the intersection of other factors is removed from that tool. And they are aware of that, so they know they are in increased risk, but nothing is done specifically to them or to alleviate those inequalities. So they do have a bit of a worry about, okay, we know this, now what? I asked them as well about what they thought about the CTG, just the technology that we are currently using, and they feel there's a huge gap between that machine and them. So what happens is that they feel there's some unmet needs. They don't feel like, when the clinician comes into the room, and as well if they perceive that the woman is not going to understand, the first thing they do is just to go straight away to the machine without even saying hello. So they do feel like they're invisible, and they have some unmet needs, which are just the basic patient normal that everybody would expect to have. That's the lack of human touch. Again, everything is what the machine says. Sometimes we know that CTGs are not used to, for example, tell the strength of the contraction. Yet some clinicians, they do like to see that on the CTG without asking the woman. And the woman is telling them about how do they feel the contractions, but the clinicians dismiss the women because they believe the technology provides an objective measure of what's happening and dismiss what the woman is saying. So they feel like there's no human touch in there, and the technology leads that decision-making and the care they receive. And also there's a lack of involvement in the decision-making. They are more suggestive what to do because the CTG tells what to do instead of being involved. And especially if they have some language barriers, or they might hear what they're saying, but they don't understand. So around the health literacy, they might not know what that means, and they feel like they're literally chained to this machine, and that is ruling what was happening with their labor and their experience. So next steps, I've been inspired by lots of people and lots of discussions that I've had today, but I would like to look at, is there any relationships between the outcomes from in the maternity data sets with, any intersections with the data that we have related to social demographics and any maternity outcomes? Is there anything different on the CTG? How to humanize CTGs. We know we are very interested in technology, but as well we need to remember that we should bridge that gap between technology and women instead of making it bigger. So it's just about how we can make it better as well. And just to explore as well, as I was saying, how can we use technology to bridge that gap between that currently CTGs and women. And also, it's just a more general question, how can we incorporate social determinants of health and the intersections of women and their characteristics for intrapartum decision making? Thank you.